the JAMA Network.
Breast cancer is the most common cancer in women worldwide, and second only to lung cancer as a cause of cancer death in the United States. Screening mammography detects breast cancer early and is associated with a reduction in breast cancer mortality. But accumulating evidence suggests it can cause at least as much harm as benefit in some women. Those harms include false positive findings that lead to unnecessary worry, imaging, and biopsy, and overdiagnosis and overtreatment when screening detects indolent cancers that would never have become symptomatic and would never have needed treatment if they hadn't been found on screening. Growing recognition of those harms led the American Cancer Society to organize an expert panel of physicians, scientists, and patient representatives to update the Society's recommendations for breast cancer screening to account for the trade-offs between benefits and harms of screening and for the personal preferences women may have about when and how often to undergo screening, given those trade-offs. The updated guideline applies to women at average risk of breast cancer, meaning those with no personal history of breast cancer, no genetic susceptibility to breast cancer, and no history of chest radiation treatment like that which some girls receive as treatment for childhood cancer. The guideline recommends that average-risk women begin screening mammography at age 45, undergo annual screening exams for 10 years, transition to every other year screening at age 55, and continue every other year screening as long as their overall health is good and they have a life expectancy of 10 years or more. The guideline qualifies the recommendation to say that women can be given the option to begin annual screening at age 40 and continue annual rather than every other year screening beyond age 55 if they prefer it or if their doctors recommend it. Finally, the American Cancer Society recommends against physician breast examination as a means to screen for breast cancer because of the lack of evidence that physical examination improves patient outcomes. The guideline acknowledges a host of uncertainties about the science of breast cancer screening. So it gives women a framework for when to start and stop screening and how frequently to be screened, while giving women flexibility of choice within that framework. The guideline concludes by encouraging all women at average risk of breast cancer to become familiar with the potential benefits and harms associated with breast cancer screening so they and their physicians can make the decision that's best for them.